Hey everyone, this is Ashley Holiday, and I have a very interesting case study to present today. Our patient is Elsie. She's a 32-year-old female who presented with headaches, cough, diarrhea, fever, night sweats, leg rash, and general malaise over the past 4 to 5 days. She has a 3-month history of abdominal distension, nausea, vomiting, epigastric pain, poor appetite, and a 16-pound weight loss. It's important to note that she has been in Mexico over the past year as an archaeologist, excavating and exploring treasures. So, after her initial uh, assessment and tests were done, her primary diagnoses were hantavirus pulmonary syndrome, valley fever, and a small bowel obstruction secondary to ascariasis. Her secondary diagnosis is severe protein calorie malnutrition. Relevant medical history includes hypothyroidism, vitamin D deficiency, B12 deficiency, and Crohn's disease. And she had a 79 centimeter ileal resection. Just to touch a little further on those diagnoses, the hantavirus pulmonary syndrome is caused by an infection with hantaviruses. It's transmitted primarily through contact with rodent secretions. It can cause severe respiratory distress by entering the bloodstream and infecting endothelial cells and the blood vessels in the lungs, which that in addition to the body's inflammatory response causes increased permeability, which allows fluid to move through. And so fluid collects in the lungs, causing pulmonary edema, which leads to impaired gas exchange and eventually respiratory distress. So that's what happened to Elsie, and she had respiratory distress and hypotension, and she ended up intubated and placed on a ventilator in the ICU and had an NG tube placed for decompression. Second diagnosis was the valley fever. It's caused by inhalation of fungal spores. It's indigenous to the United States, parts of Mexico, Central and South America. Symptoms are fever, cough, chest pain, malaise, headache, muscle or joint pain, and in some cases, rash. Treatment for that is antifungals, and then ascariasis. It's an intestinal uh, infestation caused by ingestion of these roundworm eggs that are taken in through contaminated water or food or touched in contaminated soil. And they travel into the intestines and hatch, and then can travel through the intestines into the lungs and cause some respiratory symptoms. They stay there and can mature and end up crawling back up through the trachea and getting swallowed again, going back down into the intestines where they can live for a couple of years and grow up to 12 inches long. So depending on the level of your infestation, you might be asymptomatic, or you might have abdominal pain, nausea, vomiting, diarrhea, malnutrition, some respiratory symptoms, or even intestinal obstruction. Treatment would be antiparasitics or even surgery. Just looking at Elsie's labs, I put indicators for whether or not they were high or low based off of the reference range, and then what possible indication that result would mean. And just an overarching theme indicates nutritional deficiencies, dehydration, infection, and inflammation. So, after some suspicious radiology studies, they decided to do an exploratory laparotomy, and they ended up removing 100 centimeters of necrosis in the jejunum. They removed the entire duodenum due to perforation, and then they created an end-to-end anastomosis. Previously, she also had that terminal ileal resection in her 20s where 79 centimeters was removed. Just a little reminder there. And at post-op day 4, bowel function was restored, and after that, a PEG tube was placed. For anthropometrics, Elsie is 175 centimeters tall, has a usual body weight of 61 kilograms. Her weight on admission was 53.6 kilograms. Her BMI is 17.4 kilograms per meter square, and her usual body weight is 66 kilograms. So she's about 19% less than what her ideal body weight is. For PES statement, impaired nutrient utilization related to malabsorption as evidenced by all of these low lab values: albumin, hemoglobin, hematocrit, red blood count. We're looking at anemia and iron deficiency, vitamin D, and then that 16-pound weight loss over 3 months, which is about 12% less than her usual body weight. So we have some opportunities for deficiency correction here, and obviously we want to minimize any further weight loss. Priority is feeding as soon as possible. So based on her admission weight of 53.6 kilograms, her caloric needs, her protein needs, and fluids were configured, and then those calculations were used to create these goals of 1,600 kcals a day, total protein of 70 grams a day, and then total fluids of 1,700 mils per day. To accomplish this, a recommendation was made for continuous enteral feeding of 1,050 milliliters per day of Vital Peptide 1.5 formula via PEG tube, starting at 10 milliliters per hour, increased by 10 milliliters an hour to every 6 hours as tolerated to a goal rate of 44 milliliters per hour. This formula was chosen for several reasons. First of all, it was designed for patients with impaired GI function. It is calorie dense, it's protein dense. It in general offers more vitamin and mineral support than many of the other formulations, and the density is important here because we have to be careful about volume intolerance. So you want more bang for your buck, so to speak. So that will provide 1,575 calories, overall about 71 grams of protein and 815 milliliters of water. And to reach that goal of 1,700 milliliters per day, an additional 885 milliliters of fluid is needed. And so if you divide that into 6 flushes, that would be 148 mils per flush. That could be flexible depending on how many medications she has with flushes before and after. So those numbers might need to be played with just a little. For nutrition implications, obviously, she's had some significant change to her digestive system, so she's going to have some long-term implications. So for malabsorption, the duodenum, which was completely removed, is responsible for absorption of calcium, phosphorus, magnesium, iron, copper, thiamine, riboflavin, niacin, biotin, folate, and the fat-soluble vitamins A, D, E, and K. The jejunum, which she lost about half of, is responsible for lipids, monosaccharides, amino acids, small peptides, thiamine, riboflavin, niacin, biotin, folate, calcium, manganese, and then vitamins B6, C, A, D, E, and K. And then the ileum is responsible for absorption of vitamins B12, C, D, K, and folate. And the resected ileum can affect the absorption of bile salt and can lead to fat malabsorption as well. So she might have some electrolyte imbalances like sodium, potassium, and magnesium due to altered absorption, or even potentially some of her changes in bowel habits like diarrhea. She'll obviously have alterations in gut microbiota, which can affect digestion and absorption. She's at risk for short bowel syndrome due to the amount of small intestine removed, and that would look like chronic diarrhea, dehydration, and then even more significant nutritional deficiencies. And she'll need to make some dietary modifications, which we'll talk about later. So for the functional implications, with the removal of the duodenum, which is the initial site of digestion for food, there may be impaired digestion and breakdown of macronutrients due to that reduced enzyme action, which can lead to incomplete digestion and even further malabsorption. She could have changes in bowel habits like chronic diarrhea due to malabsorption and rapid transit time through the intestines, which may also cause dehydration and electrolyte imbalances. Over time, the remaining sections of the intestine may undergo adaptive changes, which would improve the absorption capacity, but that takes weeks or months for that to happen. And just to kind of touch on some comorbidities, hypothyroidism and Crohn's disease itself are both known to contribute to malabsorption as well. So she has a lot of factors working against her here. For discharge teaching, she'll need to learn what to eat, and then based on her weight and her feeding abilities at the time of discharge, a plan should be made that helps her maximize nutrition and hopefully regain some of the weight that she lost. A low fiber, high protein diet with easily digestible carbohydrates may be the place for her to start. She should eat small meals frequently to avoid negative symptoms. She'll need education on what vitamins and minerals she could be deficient in and what symptoms of those deficiencies would look like. And she should be routinely followed up by her physician and follow up with a registered dietitian until she has stable labs and weight gain. She should be educated on that those physiological changes that she might expect, like how her bowel habits might change and how to treat symptoms, when she should call a doctor, those types of things. And then due to the bowel resection, some of the absorption of her medications may even be affected. So just looking at like a general dietary recommendation plan, not knowing exactly what discharge for her looks like, she should try to consume 30 to 35 kcals per kg per day, just to assist in weight gain. She should follow a low fiber, high protein diet with a protein content of 1 to 1.5 grams per kilogram. And then low fiber vegan sources of protein include things like tofu or plant-based protein powder, nut butter, edamame. Those medium chain triglycerides might be easier for her to absorb and digest. And that would look like coconut oil or MCT oil, coconut milk. And then small frequent meals may be better tolerated. And we would need to monitor for dehydration if she's having severe episodes of diarrhea. All right. Well, thank you for your time.